Ladies and gentlemen, dear colleagues, and just like that, we have arrived at our final eighth session of the day on a topic that has gained quite some momentum. Indeed, transcatheter LAA closure has moved from a niche option to an increasingly adopted strategy. But now questions remain about patient selection, technique, and how this therapy fits in with the broader anticoagulation landscape. This session is designed to address all of that. And to help explore the topic further, I'm joined by a great panelist, Anita Asgar from Chicago, Holger Thiele from Leipzig, Karim Azizi, and David Hildick-Smith. And without further ado, I would like to give the floor to Anita to give us the helicopter overview of the LAA, transcatheter LAA closure techniques. Anita, over to you.
Thank you. So I'm going to go over some of the currently available devices and some of the new devices. I can just get my slides to advance. Doesn't seem, oh, perfect. So, I think Nicolas already gave us a great introduction, but just to give you an idea, if we think about why left atrial appendage occlusion, these are patients who are 5 times increased risk of stroke for those patients with atrial fibrillation. And if you think about the estimated number of patients, we're looking at approximately 6 million with atrial fibrillation in the United States, estimated to double by 2030 to over 12 million patients. I'm going to give you this helicopter view of LAA devices, and I thought I would divide it up into these different design paradigms. So basically the plug-based, a dual seal type of device, conformable devices, flow-based devices, and then I won't speak in great detail, but epicardial devices that you're aware of. So in terms of plug-based, obviously this is the most well-known device, the Watchman Flex. I know there's a presentation about this not too long ago. Really best for deep anatomy, simple, reproducible, and a very long history with multiple clinical trials, including Champion AF, which just came out at ACC. Just wanted to show you the breadth of evidence with this particular device, over 9,000 patients and greater than 20 years experience, and arguably the best study device we have available. And so this is really the leader in terms of the types of devices, but there are some newer devices on the horizon that we will also talk about. In terms of efficacy, they've shown this. And in terms of safety as well, we see a progression looking at, safer and safer devices, and obviously Champion, I think, which you've already discussed or will discuss. I'll move on to another plug-based device, and this is the Amplatz or Amulet device. Somewhat similar, but as you can see, sort of a dual construction with a plug, and then almost like a cap type of feature, like an ASD occluder, which covers the os of the left atrial appendage, has some stabilizing wires, and thought to be perhaps less prone to thrombus with this recessed proximal screw. And if you can see how this seats, you can see that the lobe of the device is actually designed to fit into the os of the left atrial appendage, but then the disc is there as well to seal the orifice, the waist to maintain tension between the lobe and the disc, and also allowing the disc to self-orient, and then these stabilizing wires that engage the left atrial appendage and hold the device in place. And this is courtesy of David from EuroPCR. If we think about newer devices, this is the conformal left atrial appendage device. And this device is a foam-based device. It is a smooth, non-thrombogenic ePTFE for the exposed LA surface. There's no attachment screw in this device. And as you can see, there's this conformable biocompatible foam matrix, which seats itself into the device, and then a removable tether that can be taken out once the device is in place. It has about a 10 to 15 millimeter landing zone. And as you can see here, it's got this compliant nitinol endoskeleton and then this distal foam bumper. This is currently in trials and was just recently purchased by Gore Medical. So you can see a little bit about how this device functions. This is how this is a cartoon of it seated in place. I don't know if this video is going to play. Here we go. So this is just a video of how this device actually functions and how it is positioned into place. Very similar to any kind of left atrial appendage procedure, getting an angiogram to start with. And the catheter is inserted into the left atrial appendage. And then the device is advanced. And so this is a softer device. As you can see, there are no real retaining hooks. And the conformable nature is thought to be best suited for left atrial appendage occlusion, hopefully to minimize leaks. And then you have this EPTFE covering. No screws that protrude, and then a removable tether. And as you can see, this occupies the left atrial appendage with that foam, hopefully to minimize any risks of peri-device leak. And the EPTFE, hopefully to prevent device-related thrombus. So moving on from this, go to our next slide. So if we think about this particular device, this is the foam matrix cup, atraumatic to the LAA, hopefully an improved seal, potentially will permit this off-axis type deployment. Presently just a two-size strategy, a non-thrombogenic surface on the cover, and then a tether recapture system with no screws. Enables to release the device, look at the device with either ICE or TE, and then remove the tether. Moving on is the laminar device, and this is a rotational closure, so more of a flow-based type of device. Here what's happening is that the left atrial appendage volume is actually eliminated. So there's this small ball-like part that goes into the left atrial appendage, and then this is rotated, which actually occludes the left atrial appendage. It's less dependent on the left atrial anatomy, low surface area. And if you look at the footprint, just a very small star-like footprint on the inside of the left atrium. And so this is now with J&J. This has been purchased by J&J and is in a trial as well, a multi-center trial. And this is sort of an exclusionary or flow-based device where there is no real device sort of protruding out into the left atrium. The left atrial appendage is occluded, as you can see. And this is what the device looks like. This has been published in both preclinical and early clinical and is currently undergoing actual trial evaluation at present. This is another device somewhat similar to the amulet device. It's called the Lombre device by LifeTech. And this is a device as well that has a plug and then a disc that closes it. This has two devices, two components, I should say, with the device. And what's interesting about it is being able to separate the size of the plug from the size of the disc, which enables you to have a little bit more flexibility. So you can see there's a safety stabilizing anchoring mechanism. There's some 8 hooks that go around that engage into the walls. And then you have this oversized umbrella, very similar to the amulet, which would push and stent across against the left atrial appendage. Here you can see the little stabilizing hooks. And as you can see, it can be suitable to potentially various anatomies, particularly if you have a bilobed or multiple lobed left atrial appendage. It does come in different sizes where you can have the umbrella being up to 16 to 36 millimeters, and then the cover, which is a little bit larger. And it can be more adaptable to multiple types of anatomy. So if we think about just these devices, looking at a strategy and not a device, you can look at this force-based type of closures, the Watchman or the Amulet, the conformable devices like the conformal or the Lambert, and then the flow or exclusion devices like the laminar or a surgically placed AtriClip. And again, if we look at our mechanisms, radial force versus seal, more of an adaptive fit or a flow. I think the importance here is as this becomes more mainstream and we're looking at multiple types of patients that we're doing, not just those that are not candidates for anticoagulation, I think our device selection really needs to be based on the anatomy of the patient, the risk in terms of risk of stroke, anticoagulation risk, and that's going to equal our strategy. And as these devices develop, we're going to have to be choosing our devices on what's best for the actual anatomy of our patients. So future directions, I think, focusing on better sealing, less thrombosis, and as was already described, AI-guided planning. This is just one other device I wanted to show you. This has only been in animals, as I can see, but this is the Zenith LAAO system. It's a nitinol scaffold with a PET membrane, no exposed nitinol, and it's been shown to be successful in dogs so far that I've seen, not actually in humans that I'm aware of. It's just something else that's coming up on the horizon. And this is an example in an animal. This was presented last year, I believe, at New York Valves. I'll just skip ahead for time. So you can just sort of see angiogram. This is the deployment. Looks like a little bit of a teardrop type of device that sits in the left atrial appendage. And then closes. So only dogs so far, but probably coming to a human near us anytime soon. And this is what the results show. So good in terms of, including the device, no complications, but again, only in preclinical animal work for now. And so just to finish, I think when we're thinking about our patients, we're going to have a plethora of devices available in the future, looking at bleeding versus simplicity when we're looking at our patients in terms of clinical priority, LAA anatomy, and thinking about how these different devices will fit into our strategy for closing the LAA. I think probably shifting instead of, thinking about the device, thinking about the strategy of LAA occlusion, and then moving on to the device. Thank you.
Thank you. Thank you very much, Anita. That was a very interesting overview and a practical overview of the technology that is out there or will come in the near future. Holger, I have a question to you from a trialist point of view. Do you feel that we already have a device predicate to which we should compare the other devices? Or should we use these new devices still to determine the best indication for these LAA closure devices? What is your take on that?
So at least we have the Swiss Appendage trial, which was a comparison between the former Watchman and the Amulet device. At least this trial showed that both devices are relatively similar regarding the occlusion of the left atrial appendage, and also mainly also regarding complications. At least this is what we currently have available. When I see all these new devices, for sure they will have to be tested in large randomized trials. We all know about the current discussion with the Champion AF trial, with the Closure AF trial, which recently came out, and at least what I can tell you, we are a little bit more conservative nowadays with the indication for left atrial appendage occlusion. So we still do it. We use it mainly in trials. We use it in patients having had bleeding several times under DOAC therapy, but we are more restrictive. But we are not using it in every patient with atrial fibrillation who does not want to take any oral anticoagulation. At least we will tell them, based on Champion AF, that there's a possibly a higher risk of ischemic stroke. And this is something what we have to keep in mind. We are for sure waiting for the large Amulet trial, which is also important, 3,000 patient trial, which is also probably extremely important for the decision making in the future.
Yeah, yeah. So we already had this Swiss Apero trial that you mentioned. There's also the Amulet IDE trial that also compared one device versus the other device. But that is to your point. You're rightfully saying, and this is also my take, that based on what we have today, maybe we are becoming a little bit more restrictive in the indication for LAA closure. And I'm still wondering whether we should continue comparing one device with the other rather than focusing on better refining the proper indication of transcatheter LAA closure. But this definitely will also the topic of David when we are at the end of this session. But in the meantime, LAA closure, transcatheter LAA closure, is also further evolving from a technical point of view. And I think Karim already demonstrated last year during TIO that it's feasible to do transcatheter LAA closure under local anesthesia with just ICE guidance. And I think this has been such a compelling demonstration that has been replicated by others that I think it's high time to have a tutorial on how to do LAA closure under local anesthesia. So Karim, the floor is yours.
Thank you so much, Nicolas. Glad to be with you today. So I'll be talking about LAO closure under local anesthesia. These are my disclosures. So a little introduction, as Anita highlighted, LAO is increasingly being utilized as an option for patients that are not good candidates for anticoagulation, high risk for bleeding. TE has always been the method of imaging and guiding these procedures. And with TE comes along a package of things, including anesthesia, including arterial lines, depending really on the institution and the workflows. It is a resourceful procedure, but there has been an uptick in the technology and development and evolution of intracardiac echocardiography to trying to reach a quality similar to transesophageal echo. The one thing we want to approach when we talk about ICE guidance for left atrial appendage closure, it is more of an approach rather than the actual tool of imaging in guiding the procedure. The imaging tool is just one piece of the whole algorithm that involves this. And so with ICE guidance versus TE guidance, these are the things that we think about holistically. TE does require general anesthesia, intubation. There is a risk of esophageal trauma. We've seen that in general with structural heart procedures, but just remember that these patients are already at a higher risk with bleeding problems. Some of them may have varices. It can increase the length of stay if the patient remains under, and some of these patients tend to be older and may take some time to recover. It does require anesthesiologist plus minus an advanced imager if the anesthesiologist is perhaps doing the imaging themselves. But the advantage is you're using a TE probe that perhaps can be prepped over and over again. You have a full 3D evaluation with the 3D probe. And there is obviously a process or time in, time out in order to change that room and get it set up with all the anesthesia machines and whatnot. In terms of ICE, treat it more like a left heart catheterization that comes to the cath lab. Requires conscious sedation, no intubation required. There is an upfront cost, obviously, for the disposable probe, although this is still an area where it is being looked at for perhaps reusing these probes. Experience, obviously, is dependent. It does have a learning curve. There is less personnel really needed in the room. You do not need an anesthesiologist. You don't perhaps even need an advanced imager, as they continue to be needed in other procedures, complex structural heart procedures, and can actually be done by the operator and an echo tech that may be perhaps operating the echo machine. Improved patient comfort. There is no intubation involved. There is no endotracheal. There is no TEE use as well. So a lot of it is being done transfemorally. And the biggest issues with it is that the current technologies that we have may have certain limitations at certain degrees, specifically the 90-degree angle due to the reduction in the imaging elements at that point. And a lot of it, we see an increase in fluoro time in these cases in general. So some evidence very quickly supporting ICE guidance versus of LAO essentially versus TEE. This is from the SURPASS registry looking at patients being treated back in 2020 to 2021, 2,000 patients. And what we found is that ICE is very similar to TEE in terms of a complete left atrial appendage closure, but ICE had a higher rates of pericardial effusion requiring intervention at that time. But what we've noticed is that as we continue to actually get better with the procedure and being able to manage being the imager as well as the operator, actually the risk of something bad happening and complications have come down significantly. Looking at a similar registry, looking at ICE versus TEE or ICE plus TEE from the Emerge LA post-approval study of the Amulet device, we found that adverse events were similar between both groups. So we did see over and over again, actually, the repetition of this as the technologies improved, the procedure workflow has been refined, that we're more than likely to see similar outcomes between both imaging modality. This is a limited experience using the Amulet device from our site with 137 patients being done just with conscious sedation. And again, this is the difference. The highlight or the focus involves patients being administered midazolam and fentanyl that basically with very minimal or light sedation and local anesthetic, mostly Amulet in this workflow, as well as Philips 3D VeriSight Pro, and we had very good outcomes in general. This was recently presented at CRT with a publication coming soon. Need for prospective data, obviously it's a question that keeps coming up. Do we have prospective evidence to compare this two holistic approaches of TE versus ICE with the promise and the idea, the fact that we are giving these devices to take off patients off anticoagulation? The biggest thing for us is to avoid procedural complications, but also provide an adequate seal without any leaks. And so we're conducting this prospective randomized control trial called ICE-T that compares ICE guidance versus TE guidance in 440 patients, 220 in each arm, looking at endpoints that involve not only procedural safety, but also closure and no leaks at 45 days. Here's a case example of how this evolves. This is an 82-year-old gentleman with multiple comorbidities, elevated chest VASC, and has bled, was enrolled in the clinical trial. These patients undergo CT evaluation, provided that their kidney function is appropriate, although as low as a GFR of 25, 20, or 30 cc's of contrast can be used to actually obtain these CAT scans based on certain protocols. This is just the CT scan looking at the appendage, but not only the appendage, but also looking at the septum in order to plan the transeptal access appropriately. The patient is usually sedated with midazolam and fentanyl. It's a lean cath lab team, usually a nurse, a scrub tech, and another monitor person. Ultrasound guided access in the right common femoral vein with two adjacent access points. The lower is for a 10 French lung sheath, typically for the intracardiac echo. And in this case, we were using the 9 French VeriSight Pro catheter. And the upper one is reserved for the actual device. In this case, we've used the Baylis sheath, a BRK needle, and as soon as access is obtained, the patient is heparinized with a goal ACT of greater than 250. We size the appendage, obviously based on the CT, but also based on, at the time of getting a transeptal access, looking at the appendage. These are the steps. Number 1, ruling out pericardial effusion, as you can see from the home view. Number 2, also getting a side view of the right ventricle by just leaning within the tricuspid valve and looking at the left ventricle as effusion may accumulate by the posterior wall as the patient is laying on their back. Excluding LA thrombus before transeptal is a very important piece, although very rare. You may be able to get that actually from a couple different views. This is just a modified fossa view where where the ICE is positioned in the right atrium, looking through and far into the far field into the left atrial appendage. Subsequently, transeptal access is obtained. You can appreciate here the power of beyond 2D ICE. And that's the purpose of this, is the 3D ICE capability is the ability to obtain different angles without having to move the catheter in different ways. And so in this case, we are utilizing the X-plane capability and able to see both positions, a superior, inferior, as well as an anterior, posterior on the right panel, making sure that we are in a posterior, inferior position. Once transeptal access is obtained, the wire is placed in the left upper pulmonary vein, and a 14 French amulet sheath is typically used to floss the septum. The ICE catheter is still in the right atrium at this point. Once the catheter is used to floss the septum, it is retracted back into the inferior vena cava, and then the process of getting the ICE catheter is processed to actually get it into the left atrium. These are the steps. Typically, it is ICE guided or ultrasound guided, but also can be done by fluoroguidance by actually moving the gantry, either RAO or LAO, in order to make sure that this ICE catheter is essentially in parallel or married to that wire. And once it is seen that it is actually attached or close or dancing with the wire, it is advanced gently, and immediately you'll be able to visualize the catheter going across without buckling into the left atrium. And on echo or under the ICE guidance, the first thing or first structure you'll be seeing is the mitral valve. In typical fashion, an appendogram is being taken with the pigtail, because after the ICE catheter is being introduced in the left atrium, the delivery sheath is further introduced into the left atrium. A pigtail is placed and an appendogram is taken. Then the imaging is being performed. There are two key views in the left atrium, a mid-LA view, as well as a supramitral view, where we are able to actually obtain very clear images, very direct images of the left atrial appendage with a clear imaging of the sizing in different angles. Subsequently, after the device is being actually chosen, and these are just different angles. This is the supramitral angle where the ICE catheter is laying on the mitral valve in order to look superiorly to the left atrial appendage. The device is then being inserted in the appendage under ICE guidance and fluoro guidance as well. And hence, here's sometimes where the fluoro time may be increased as compared to TE guidance when it comes to ICE guided procedures. Here you can appreciate the placement of the lobe. An appendogram is actually performed at this point, confirming its insertion within the body of the appendage. And once that is confirmed in the usual fashion, the disc is then applied to the device. And you can appreciate here on the multiplanar reconstructions, not only the very nice 3D images, but perhaps the ability to interrogate different angles by moving the crosshairs and changing the angles in general. Once that is performed, a typical tug test is done to confirm stability of the device, and that is also nicely visualized here on the ICE imaging as well as on fluoroscopy. And the device is then, after that, released. Final images are then taken by the intracardiac echo to confirm that the device has settled in nicely, as you can appreciate in these images. And finally, a check for pericardial effusion at the end of the procedure is being done, again, with a little lean within the right system onto the tricuspid valve in order to replicate what looks like a four-chamber view to appreciate effusion. So, points of consideration very quickly for ICE. There is a learning curve. There is there are multiple steps. Obviously, it has many advantages, including eliminating GA and the alleviating the scheduling complexities and perhaps personnel that may be needed for other procedures, but it carries also the complexity of the learning curve as well as the cost of the catheter in general. I will conclude that ICE-guided LAO is feasible, though there is a learning curve. There are current indications for LAO already are causing a strain on the system in coordinating resources, and it does require a meticulous assessment for sizing using MPRs to streamline the procedure. Post-device assessment of leaks is extremely important, and using 3T capabilities from MPR is very helpful and important to prevent visualizing PDLs hopefully down the line. LAO procedures can become as lean as a left heart cath, like we've done with many structural procedures like TAVR, for example. Just require an additional personnel in the room, an echo tech. And data on all comers for ICE-only moderate sedation is limited and retrospective, and prospective data is yet to come. Building a moderate sedation ICE-guided LAO program definitely has advantages, despite the financial stipulation of the ICE catheter cost, the efficiency, the lean teams, no time constraints, and patient satisfaction. Thank you for your attention.
Karim, thank you very much. This was a very nice an illustration of how to do a step-by-step ICE-guided LAA closure. In your opinion, are we there yet? And is this technique democratized so that more sites and more physicians can adopt this technique? Or is it just for the happy few with good hands and a good appreciation of imaging?
No, that's a great question, Nicolas. I think we are still in the beginning. There is a lot of hype, obviously, about the approach, the ability to accommodate more patients. There is that learning curve that we all and our team has gone through that over time becomes a second nature, just like many other procedures. If you think about TIO, for example, it is a complex procedure. It's not democratizable immediately to everyone. There is a learning curve. But perhaps what adds to the complexity to this is imaging, and imaging, being an imager and an operator at the same time, definitely complicates the piece. And so there's also the patient selection piece, which needs to be very important. Patients with restless leg or issues with anesthesia that perhaps may not be good candidates for moderate sedation, but also on the other side of general anesthetic is an important point to keep in consideration.
Anita, have you already adopted this technique?
We haven't, but I will say it's attractive for many reasons. And a lot of us are suffering from the ability to get general anesthesia and having that anesthesia time. And so we are very enthusiastic to start doing this. There are some other challenges. I was curious, Karim, how you manage air, air management in some of these patients, just to make sure, because they are awake and they are breathing. And if they Valsalva, there is that risk of air going from the right to the left side. Our team is on board, but, there is a learning curve, as you said. We're quite familiar with ICE for tricuspid, but on the left side, a little bit more challenging. Maybe you can speak to the learning curve a little bit more, how many cases you think, and, how long it takes a team to get up and running to switch over completely.
No, that's a great question, Anita. I'll start with at least how the program is really built. It takes a lot of buy-in also from the nursing staff that you have in the cath lab. It was a conversation, understanding the importance of maintaining sedation at a moderate level and not beyond. So actually, to prevent air embolism, what we've emphasized on is avoiding deeper anesthesia that the patient actually would lead the patient to snore, for example. So we would stay on the lighter side of things, set the expectation for the patient, rely on the fact that the patient is just relaxed, comfortable with a lot of local anesthetic. That's one piece. The second, from a learning curve standpoint, what we've seen is anywhere between 5 to 10 cases where you start in the beginning, a first few cases with concomitant ICE and TE at the same time. And so slowly take out the training wheels, just so that everyone in the room is actually comfortable with how the patient is performing, and also the operator is comfortable in managing the ICE catheter and the imaging tools, etc. And over time, what we found is that our team has become smaller and smaller in doing these procedures, and perhaps not within the constraints of we have to do these on specific days, or we have to do these between the hours of 10 to 4 due to anesthesia coverage availability.
Holger, the pivotal trials have identified periprocedural complications, and for that matter, periprocedural bleedings, as one of the issues related to transcatheter LAA closure. Do you feel that ICE-guided procedures may mitigate these complications, or and would you then also recommend this in future trials, or are we not there yet to make that statement?
So I'm looking forward to the ISTE randomized trial. Probably this is very important for making decisions regarding your questions. I'm not sure if we really will be able to reduce complications. At least the major complications we often see during the transeptal puncture procedure. I'm not sure if ICE will help us in this situation. And overall, the LAO occlusion procedure is a safe procedure in experienced hand. I'm not sure, but we will have to look for the randomized trial. I'm not sure if the trial will be sufficient to also show safety, or if it will be sufficiently powered, but we will have to see. At least what I can do, we haven't used it so far. We use it mainly as eyes for T-tier procedures when we have not optimal image quality. This is where we currently use it. And this is very helpful, in particular, if you have no sufficient windows with TE. And that's the reason why we use it mainly in these procedures.
So, Karim, remind me, what was the primary endpoint of the IST trial?
So the primary endpoint is a safety endpoint, Nicolas, looking at essentially safety and freedom of any events at the time of the procedure, but it's also a composite with secondary endpoints that looks at leaks at 45 days or 3 months on the follow-up that is being done for those patients. We do have actually in the secondary endpoint things including an anesthesia questionnaire for the patients to kind of reflect on the patient experience in general. Which is an approved anesthesia questionnaire. And also we're looking at obviously financial performance and individuals or personnel that are within the trial. But it's also important and interesting enough to bring it up to the team that as we bring up lower risk patients within the Catalyst trial, which we're part of, they allowed ICE implementation in certain patients once there is approved number of ICU. So there will be, I will think that there is an ICE subset that we will start seeing specifically in the lower risk population as well, which I think will also shed some light on how this performs with more and more up-to-date approaches to this procedure and devices.
Yeah, so both Catalyst and IST are definitely interesting trials to look forward to. Thank you for that. So, okay, with all this in mind, the question is LAA closure a true alternative to oral anticoagulation, or does it remain a therapy reserved for those in whom anticoagulation is contraindicated? And we have some data from 2 randomized controlled trials that were recently published in the New England Journal. So over to David to tackle this topic.
Okay, great. Thank you very much for that introduction. Yes, well, this topic is a little more difficult than it was a year ago because, as Nicolas just said, of closure AF and champion. So if we take ourselves back a year, the thinking generally was, okay, LAAO is equivalent to anticoagulation in terms of stroke prevention, but importantly, will limit the amount of bleeding that you get because you're not taking a DOAC or warfarin. That stands to reason. That was pretty much where people's thinking was a year ago. In addition to that, the trial evidence was getting quite old that had suggested those things were true. And we now had other reasons to be cheerful because of learning factors about left atrial appendage occlusion. I've listed 4 there. So procedurally, we were getting better at it. The complication rate was going down. For DOAC treatment, it was clearly known that still, despite the change of warfarin, compliance was pretty poor and only a certain proportion of patients were ever taking the tablets regularly. And then, although the procedure itself is expensive, if you compare it against DOAC that you're taking every day in perpetuity, there comes a time when it's financially advantageous to have had a single one-stop procedure instead. And then, of course, finally, the devices themselves were iterating and getting better. So there were lots of reasons why people sort of assumed that LAA closure should at least be non-inferior to DOAC therapy, right? Anyway, hold on, because we got a bit of a slap in the face with Closure AF. And many congratulations to Ulf Landmesser and the team in Germany who produced this study, which confounded a lot of people's expectations, mine included. So this study, 900 patients, this is more like the group that we in Europe probably treat. You know, Chad's VASC average 5, Hasbled 3, mean age 78. They're sort of elderly, developing, frail sort of group of patients. And we need to, look at the results of these and take it seriously. Surprisingly, perhaps, left atrial appendage closure was effectively not non-inferior. It sounds like a tautology, but it makes perfect sense, really. And that was with the primary endpoint of stroke, major bleeding, and death. When we looked at the individual endpoints of this study, ischemic stroke, which is supposed to be less frequent with this device, was not. Hemorrhagic stroke was supposed to be less frequent because you're not taking the DOAC, but really no difference and quite low incidence. And actually most striking was the fact that there was bleeding in equal amounts in the left atrial appendage occlusion group, even though they weren't taking the novel anticoagulants. So fast forward a couple of weeks to Champion. Champion comes out with 3,000 patients. It's written up rather differently, but actually many of the findings are much the same. This is a lower risk group, CHAS-VAS 3, Hasbled 1, mean age 70. So this is a sort of directly versus DOAC group of younger, fitter patients. But the primary outcome, which was essentially stroke, plus a little bit of contribution from death and systemic embolism, was not any better. In fact, it was numerically worse with the device than it was with anticoagulation. And again, when you look at the individual endpoints, ischemic stroke was actually more common with the device. Hemorrhagic stroke was very rare in either group because of the fitter population. And again, major bleeding was significantly problematic for the appendage occluder. It was presented in the New England Journal as non-inferior because all the procedure-rated bleeds were excluded. But that's a bit like a DOAC company doing a trial and excluding all the post-procedure bleeding. It's definite cherry picking, and I don't think people are necessarily completely taken by that finding. So I did a little quick and dirty sort of meta-analysis here. What you can see chiefly is that these are Protect, Prevail, PROG 17, Closure AF, Champion. If we look at ischemic stroke, which is sort of the primary role of the device, it's clear that the trend is generally that the device is worse than DOAC. This is disappointing. If you then look at hemorrhagic stroke, there's not really possibly enough of a clear signal. Everything crosses the midline. If our clinical fellow, Mohammed Abdul El-Assad, looked at the composite endpoints a little bit more closely, and I won't go into it in too much detail, but basically what this shows is that for the primary endpoints, is really, ever since Protect, the results have just got sort of worse and worse for the left atrial appendage occluder, oddly. Ischemic stroke, definitely a trend to be worse with the appendage occluder. And in terms of hemorrhagic stroke, not much obvious signal, and bleeding, definitely no obvious improvement if you're having the appendage occluder rather than the daily anticoagulant. So, put together, these are some pretty serious holes in the current appendage occluder theory. Yes, it's a very promising therapy. It should be a good alternative to DOAC. But we're seeing clot. Why is it not working? You know, we're seeing clot on the device in up to 5% of cases. Well, that frankly rivals what's in the appendage. You know, when you do these cases without pre-screening, you get a 2 to 4% rate of having to cancel the case because there's a clot in the left atrial appendage. Well, that's not dissimilar to what they're seeing here. So that's not an achievement. Incomplete closure is problematic, actually, because even about 20% of cases, there is incomplete closure. Obviously, we need to close the appendage, ideally, otherwise that is linked with recurrent stroke. And then procedural complications, you know, for a preventative procedure, 4% is too high. And then, disappointingly, the more minor antiplatelet regimes still seem to provoke bleeding, which is, you know, not wholly unequivalent to that of DOAC. So there's quite a lot of work to be done in the left atrial appendage sphere. The devices need to get better, definitely, and the doctors need to get better as well before it's actually really going to rival DOAC therapy. What about those who are unsuitable for DOAC? Well, those traditionally have been the patients that we have treated in Europe. And I guess now we have to say, well, the assumption that older and more infirm patients who can't take DOAC will benefit from appendage occlusion is actually unproven. We couldn't do the trial. ASAP-2 stopped because the therapy was too broadly available, so nobody would randomize themselves into it. They believed they wanted the appendage occluder. The doctors believed in it. But these older, frailer patients will have higher procedural risks, more bleeding, the procedure, more post-procedural bleeding, and they may well not live long enough to gain potential benefit. So unexpectedly, we're in this position that it's now no longer obvious that this kind of patient will benefit from current generation appendage occluders. And actually, to be honest, you know, the ideal patient for this therapy may still be the younger person who gets AF age 60 and gets an appendage occluder and then gets 20 years use out of it. Maybe in the longer term, the benefits will become apparent. Thank you very much.
Wow, David, so you were ending there on a provocative note, and I would like to pass that to Holger. So, Holger, do you feel that we need a randomized controlled study in patients who don't tolerate or have a contraindication for DOAC? Is that still a patient population that requires a randomized controlled trial? I think you're muted, Holger.
Excuse me, yeah, I've been muted. Sorry. Yeah, for sure, we need randomized trials in the setting, and there are ongoing trials in this setting. At least what I know, what we currently do in Germany, there's one where we also participate. It's a so-called left atrial appendage kidney trial, which is a trial in patients with severe renal failure, so stage 4 and 5, and these patients are randomized to best medical care, where we currently do not know what is best medical care, because we usually are not allowed, or at least we have contraindications for DOACs in this situation. And this is a randomized trial of left atrial appendage closure versus best medical care. This is ongoing. So far, I know a little bit more than 180 or something like this patient have been included. It's not a trial with several thousands. It's a trial with several hundreds, but this will be an important trial. And then there's another ongoing trial also organized in Germany, which is a trial in patients having had intracranial bleeding. And these patients are also randomized to best medical care, which is in part allowed to take DOACs versus left atrial appendage occlusion. So these are specific subgroups which have not been randomized in the trials, at least not in Champion AF. Maybe partly they have been included in our Closure AF trial, but I'm sure that we will find at least a niche where we will have a clear indication for left atrial appendage occlusion.
Yeah, so it's remarkable that you find the patients for those trials, because in the Netherlands we tried with a randomized controlled study, and that was prematurely closed down because of slow enrollment. Anita, do you share the same conclusion of David, that probably the best patient for this therapy for the time being is the very young patient, the younger patient? Because I was a little bit concerned about this signal of more cerebral stroke, so it's more stroke events in Champion AF. What is your take on that? Oh, okay. Apparently we lost Anita. So Karim, can you take that question then?
The biggest thing,
And you're muted.
Is one of the biggest things. Can you hear me okay?
Yeah.
One of the biggest things that we know about the left atrial appendage closure, there are two folds to this very important conclusion that we just heard in this very elegant talk. One, do we have really the final device that purely excludes the appendage? Because we know, even though the IFU says 5 millimeters or up to 5 millimeters, we have shown over and over again that peri-device leaks have been linked to stroke events. So as we ventured into lower risk patients, that becomes the question. If we reflect on the Amulet IDE trial, we've compared Amulet to Watchman. Perhaps Amulet was a little superior in closure, but had the risk of effusion. So there's more to come on that front. The second piece is that when we think about closure in younger patients, we need to think about rhythm management. We have to think about how to approach those patients. If you talk to electrophysiologists and we talk to colleagues and we hear from the societies, those patients can be treated earlier on with rhythm management, a lot of times can be monitored and may not even require anticoagulation after, which begs the question, do we really need to put in a device in all of them earlier on? So I think whenever we approach this, we have to also approach it from a rhythm perspective, because as we get younger and younger, the question of anticoagulation is not the only question, but perhaps pulls with it the rhythm piece as well.
That is excellent. So a fitting note to close the day, I would say. So Holger, Anita, Karim, and David, thank you very much for paneling and for joining me in this last session of the day. And as this session draws to a close, let's take a brief look at today's highlights.
So, Henrik, jetzt gehen wir noch was essen, ja?